This afternoon's presentation, the first topic has to do with management of a gummy smile. Our first speaker is Dr. Oscar Gonzalez. I first saw Oscar at the Spanish Society of Periodontology 2 years ago, and I was really impressed by his presentation, and I'm so happy that he joined us for a presentation just for our periodontology residents last year, and now we were able to invite him to come and present. Yesterday he gave a presentation at the restorative track, so he's going to talk one this afternoon on the surgical management of the gummy smile. Oscar got his DDS degree from University of Seville, and he did his master as well as periodontology training, and it's from the PerioPros program at University of Pennsylvania. So you can see we have several people from University of Pennsylvania represented, including the program director, Ernesto Lee. So he is a visiting professor at University of Geneva, as well as a faculty in the graduate periodontology program at Complutense in Madrid, under Mariano Sanz. So it's really a pleasure to welcome Oscar, and I'm sure you're going to enjoy his material. So please help me welcome Dr. Oscar Gonzalez.
Thank you. Thank you very much for this kind invitation. It's a great pleasure to have the opportunity to present in this forum. And as you may imagine, for me, it's an honor, and I'm very happy and humble. So when I get the invitation from Professor Sade, he asked me to talk about crown lengthening, or aesthetic crown lengthening. And before I start, I would like to explain to you where my funny accent is coming from. I'm originally from Sevilla, and many of you guys have been there for sure. It's the place for the flamenco and tapas. And basically, after I finished my DDS, I started working as a pediatric dentist. So it was too much for me. So after 6 years, I say, okay, it's enough. Let's try to move on. So after 6 years, I decided to solve everything, and I moved to Philadelphia. Philadelphia, as you know, has this combined program in periodontics and prosthodontics, and that was my goal, try to be trained here in US, and I get that opportunity. And after 4 years, I decided to move to Geneva in order to get training in the field of aesthetic and restoration and minimally invasive dentistry. And after that, I have to go back to work to Madrid to pay back my tuition. I think that I really finished to pay last year. So it was a long trip. So the topic for today, I will try to share with you some ideas about aesthetic crown lengthening, which is a very critical treatment that we have to face from time to time. Once I take the opportunity to say thank you to all the people that I used to work with, but in this special lecture, I want to thank to Ernesto Lee, because he was the first one who really gave me another perspective about how to really look at this type of treatments. So today when we talk about aesthetic, there is no question. Today we talk about white and pink aesthetic. And we are all periodontists, so we work in this area, and wherever we have to design and smile, we know that any of the checklists out there, they focus more and more in the importance of the pink aesthetic. So there is no question today that the harmony in the final restoration is coming from an interaction between the lip, the tooth, and the gum. So we really need to take care of all these factors in order to get a nice and aesthetic result. However, there is some clinical situation that break the natural harmony. And we are all aware of them. Sometimes we have an excess of pink, and sometimes we have a defect. We have asymmetries. We have inflammation. At the end of the day, it has been published a long time ago that we have some problem coming from a defect in the pink area, recession, loss of papillas, collapse. And also for an excess, like gingival hyperplasia, short tooth, and irregular alveolar ridges, or the combination of many of them. So we are very, very used to work in these type of situations. When the disharmony is missing because we have an excess of soft tissue, there is a treatment that we do very, very often, and it's called anterior crown lengthening. And basically, it has been published here in US that is a very common procedure, especially 10% of the periodontal surgical procedure that they are referred to a periodontal specialist is anterior crown lengthening, which is a lot. And we must say that in the way that we do anterior crown lengthening is fine. It's a predictable method of gaining crown length. So there's nothing wrong with it. There's nothing wrong with it. But we have some issues with this particular treatment. And they are the problem that we have with the predictability and the stability of the gingival margin. That means that we are not always able to let the gingival margin where we want to have it. We are not that good on that. And it has been published that 49% of the treatment that we do, at the end, we have a great tendency for the teeth to be shortened than what we decide. So we wanted to get it there, but many times we don't have enough to achieve this treatment. And moreover, we have a tendency for marginal soft tissue rebound after 3 to 6 months following anterior crown lengthening. So this is the problem that we face. This is the problem that we face. When do we use that? Well, we all know that, to reestablish the gingival harmony and the relationship between the gingiva and the upper lip. These are the 2 main indications. And 3 are the problems why we have to do this type of treatment. Because we have an alteration of the eruption, of the development, or we have an inflammatory pathology, or because we have some restorative purposes. Let's very, very, very quick pay attention to that. So when we are talking about alteration of the eruption, of the development of the patient, we have 2 different ball games. We have those cases where the eruption is altered, or those situations where we have a maxillary vertical overgrowth. And we are all aware that this second problem is not always possible to be solved with an anterior crown lengthening. We have to go for something else. And we know from many years that we can have an altered active eruption or an altered passive eruption. Both of them, at the end of the day, is going to give us something similar, that the tooth is going to look shorter. And this paper is a classical paper that many of you have read for sure. And even many times I'm not able to remember if my patient is a 1A, 1B, because I studied many times, but at the end of the day, I never remember. They pointed out 2 of the most important factors to be taken into consideration, which is the amount of the keratinized tissue and the location of the crest related to the CEJ. And they are crucial if we want to have a nice result and a controlled treatment. So at the end of the day, these teeth are going to look short. And of course, we have inflammatory pathology that can be so aggressive like this. And for sure, this tooth will look short. But there is a 3rd type of situation where we have to go and do an anterior crown lengthening, which is the restorative purposes. And we have mechanical reasons to do that, to increase the retention and the resistance of our restorations. Or because of biological reason, because we need to avoid a biological width invasion. Or only because of aesthetic reasons. In this particular situation, we are not dealing exactly with a short tooth syndrome, or not necessarily. So how we can establish or reestablish the desired harmony? So we all know that. All of you have been exposed to do an anterior crown lengthening in your life. So I would like to share with you a couple of cases, very simple cases. This is a patient with a gummy smile. We have also an excess of maxillary growth, but we are not going to be able to clean all this situation just because of we are going to do this anterior canal lengthening, but we will improve it. Not only that, we're going to try to reduce a little bit in this area by lengthening these teeth, and not only that, we're going to try to get some symmetry in the gingival margins. That's fine, that's not difficult. We're going to position the central incisors. We're going to see what is the aim of our treatment. We're going to do our gingivectomy. And then we're going to open the flap. We're going to raise our gingival flap. And then we're going to try to create enough space for the new biological width. That's the only aim. That's what we're looking at. This is the aim of our treatment. And of course, in most of the situations, we get nice results. And you all are very experienced clinicians. And you're used to do that very often. And at the end of the day, we have a nice results. And we're coming from here to this situation. Simple, easy. You have, all of you guys has cases exactly like this. Let me show you case number 2. It's very similar. Square teeth, gummy smile. Periodontal health, nice occlusion. She's calling me, cut my gum. I have more teeth below. So let's see. We're gonna take a look. It looks fine, it looks nice. Everything looks just to go and cut and paste. And first thing, we measured 9 millimeters. I would like to have 10, 10 and a half, 11 millimeters. And the first thing that we are gonna do is to do bone sanding. All of you guys are used to do bone sanding. However, most of our studies are showing us that we are not that predictable doing bone sanding because it's a blind technique. So many times we're not able to make sure what is the real anatomy of this bony crest. The next thing that we do is to try to know where the CEJ is. Again, can you all promise that you're gonna measure 100 patients and you're gonna locate the CEJ in 100 patients? I will not. Because we all know that there is different anatomies in every single patient. Some CEJs are very prominent. Some of them are very, very, very smooth. So, we are doing a procedure taking into consideration 2 factors that we're taking blind. The position of the CEJ and the position and anatomy of the bony crest. And the next thing that we're doing is to do something which is non-reversible, like is a gingivectomy. So we are taking 2 diagnostic factors in a blind way. So, but I carry on with the case, and what we did is we measured what we thought the measure is going to be. We took the symmetry and position of the zenith. That was done at the university. And gingivectomy, in this particular case with a laser, it really doesn't matter. And then we start to see that we had some square teeth that didn't look that square anymore. Gingivectomy, raising the flap, it doesn't look square anymore, but triangular. Plus, even with this huge screen and with an open flap, can you really tell me what is the CEJ? It is not easy. It is not easy. And also, can you promise me that always the CEJs are at the same level? We all know that is not true. But many times we don't take that into consideration. And I promise, we tried to see that before, but we couldn't. It was blind. I tried to do my bone sanding, but it was not great. So at the end, we are facing with a situation, and now we have to start removing bone in a situation like that in order to create a space for a new biological width. And, well, this is what we did. And that's what we achieve. And of course, at the end, we are going to have a feeling in this area, even I was not quite sure. 2 months, the healing is not nice. Now I can see my CEA, which is not at the same level as the other one. And for me, this is a failure. And it's my failure. But for sure, we can do it better. So my first message, especially for people that is starting to do this kind of procedures, is that there is no such a simple case when we are dealing in the anterior part of the mouth. And where was the error? Because to be honest, my first case has all these things, and also my second case. I mean, they have many similarities. Young patients, arthro passive eruption, periodontal health, high smile line. So where are the differences between the first and the second? Where is my error coming from? First of all, the technique itself, it doesn't give me all the information because it's a blind technique. I don't know what is the CEA. I don't always know what is my alveolar bone. And for sure, we have to take into consideration the tooth form that we can really check by doing an X-ray. Look at the case.